Action.
Hi, I'm Dr. Art Bartolozzi, and I'd like to talk to you about the rotator cuff. You've all heard about rotator cuff or bursitis or tendonitis around the shoulder, so I'd like to discuss with you exactly what these problems are all about. The rotator cuff is a series of 4 muscles that basically, if you look at this model, which comes from my right shoulder, so this model is a right shoulder model, and the rotator cuff is a series of muscles that keeps the ball in the socket. So when the rotator cuff muscles are not working, the ball tends to ride up in the socket. As a result of that, as I'm going to show you, the rotator cuff tendons are damaged. In the shoulder, unlike the hip, there's a bony roof, and the bony roof can pinch on the tendons. So if you can look at this carefully, I'll show you that as the arm comes out to the side, so as we bring one's arm out to the side, this tendon will pinch on that bone, and you might imagine when that happens over and over and over again, the tendon can wear out. So it can either happen as a result of overuse or too much use, or it can happen from a sudden fall. So a sudden fall on the elbow or a sudden fall on the outstretched arm can cause damage to the rotator cuff, and you can see where in this position right here where the pinching occurs. So I'll show you that. Where the pinching occurs, the tendon can be pinched, and I'll show you as it kind of gets caught under the bone. And that's the mechanism of rotator cuff injury. Now, what happens if you have a rotator cuff injury? The most common presentation is in patients over 40 years of age. So usually it's 50 to 70, and the symptoms are pain at rest or pain with overhead activities, oftentimes pain when you're sleeping that awakens you from sleep. In the most severe cases, when the tears are large, you can't lift your arm, and in those cases repair is more difficult. So the most common injury is a small tear to one of the tendons called the supraspinatus tendon. And what's very interesting is when I trained 20 years ago, we often would treat most of those injuries conservatively for 2 reasons. The diagnosis did involve an arthrogram because it was before MRI, and the surgery involved a large incision, splitting or removing or detaching muscle and opening the shoulder. Now what's changed is we know from natural history studies that if you have a small tear, it can progress to a large tear. So it's important in many cases in younger patients and more active people to intervene surgically. Now, not all people need surgery. If you have a tear and don't have pain, it's important that we keep an eye on it and follow it, often with serial MRIs, or follow your symptoms. But it turns out that if you have a small tear, there is a significant chance that it can go on to a larger tear. Why does that matter? Because a small tear is fixable arthroscopically with 3 or 4 small stab wounds around the shoulder where we put fiber optic cameras in and surgical instruments that we can operate in very tiny spaces. If the tear becomes very large, and oftentimes that can take some period of time, then in some cases the tear is not repairable, and unfortunately we can't fix that. There are patches and a variety of materials that have been tried, but nothing really works better than your own tissue. Now, who needs a repair? Anybody with activity that involves overhead lifting, or if you have a sudden onset of pain and weakness as a result of a fall, we often will fix those injuries. Certainly if you're young and you're athletic, we would fix a tear of the rotator cuff tendon or tendons right away. Who doesn't need surgery? Patients that are older, less active, and who respond to conservative measures. And the conservative measures for rotator cuff repair are activity modification, avoidance of overhead activities, for example, rest of the muscles to allow inflammation to subside, anti-inflammatory medication, and an occasional corticosteroid injection, which, if properly placed, is very effective in the subacromial space. So we do what's called an impingement test with lidocaine or novocaine. We inject that into the area, and then if it's in the right spot as you move your arm, you should have an immediate decrease in pain. That means the injection was placed properly, and the steroid, which is often mixed in, will have a beneficial effect. Doesn't work in everyone, but it's very successful in most patients. And finally, physical therapy can be very important in this condition because the muscles, as they're injured, become out of balance. And as a result of that, the ball can ride higher and higher in the socket, creating a worse problem. So that a physical therapist who understands the rotator cuff can be very beneficial. If you do therapy, it's important to not do exercises with the elbow over the shoulder level. Because if you're exercising over shoulder level, or if you're doing activities in therapy that actually increase your pain at night, then you may need to modify those activities. And finally, if nothing responds to conservative measures, anti-inflammatory medication, and activity modification, then surgery is a very effective option, and most of the time surgery is performed arthroscopically, and it can often be performed in most cases as an outpatient.